Good morning and welcome to this core curriculum session on shoulder instability. In this session we're going to discuss types of dislocation and associated injuries, what happens after reduction, and further imaging and subsequent surgical management.
Stability of the glenohumeral joint is enhanced by the glenoid labrum, the joint capsule, the effect of the rotator cuff muscles working in unison with the deltoid, and other factors such as negative interarticular pressure.
The Bailey classification is a useful classification for shoulder instability. Type 1 instability relates to traumatic structural lesions, for example, found in contact sports players. Type 2 relates to atraumatic structural lesions, for example, in patients with hyperlaxity who develop instability on a background of minor trauma. Type 3 relates to muscle patterning. The key point is that one can move throughout this triangle from one type to another depending on the effect of trauma, muscle patterning, and laxity.
In an anterior shoulder dislocation, the arm is held in abduction and slight external rotation, and the patient cannot adduct or internally rotate the shoulder. The shoulder has a squared off appearance and the distal acromion looks prominent on a side view. The x-rays are usually diagnostic, and it's said that you shouldn't miss an anterior dislocation radiologically. In a posterior dislocation, the arm is held in adduction and internal rotation, and it's very painful to externally rotate the joint. The X-ray on the APVO shows a light bulb sign, but you're reliant on a reasonable quality lateral, which may not be seen in the emergency department for an accurate diagnosis. And unfortunately, approximately 30% of posterior dislocations are missed on the initial presentation to the emergency department with subsequent medical legal ramifications.
Posterior instability is classically related to the 3 E's, i.e. ethanol, epilepsy, and electrocution. Luxatio erecta is an unusual and very striking presentation of inferior shoulder dislocation, where the patient presents with the arm overhead. The duration of sling immobilization is controversial. I tend to immobilize the first time dislocated for a period of 3 weeks, and for recurrent dislocators for comfort only. In the older patient, it's reasonable to immobilize them for a couple of weeks for comfort, as an associated rotator cuff tear can be quite painful, and to assess them after this period to check for integrity of the rotator cuff. ETOI demonstrated reduced recurrence rate in patients immobilized in external rotation in a clinical and radiological paper. However, this has not been replicated by other groups. So these are the common associated injuries, with the labrum being the most frequently involved. It's helpful to be aware of the terminology used with labral tears, with the standard soft tissue Bankart, with the displaced labral tissue, the Perthes lesion where the periosteal sleeve is intact, the Glad lesion where there is disruption of the articular cartilage, and the Alpsa lesion where the labrum is medialized and healed in a rolled up position, which has a higher redislocation rate. This arthrogram demonstrates a standard anterior soft tissue Bankart lesion.
Here we're looking at a right shoulder. We see there's a displaced labral tear. And if we look at the posterior aspect of the humeral head, we see a significant Hill-Sachs lesion, which in this case is likely to engage. And then when we look from an anterior portal, just at the bottom of the picture, we can see a displaced, medially displaced labral tear, so-called ALPS lesion, where I'm here using a liberator to release.
In this patient, there is a labral tear, but associated avulsion of the inferior glenohumeral ligament from the humeral side, a so-called Hegel lesion, which if unrecognized and untreated can lead to a higher rate of recurrent instability. Here we see a posterior labral tear. The most common fracture is the Hill-Sachs compression fracture on the posterolateral of the aspect of the humeral head. In the older age group, there may also be a fracture of the greater tuberosity. Fractures of the neck of the humerus are unusual and often associated with attempts at reduction. Here we see a bony Bankart lesion on MRI arthrogram. This is the same lesion seen at arthrography. The needle is pointing towards the small bony fragment. Here is a more complex glenoid rim fracture with associated large Hill-Sachs lesion. The size and position of the Hill-Sachs lesion has a major impact on the rate of recurrent instability.
And in this animation, we can clearly see the effect of the Hill-Sachs lesion as we externally rotate the proximal humerus. When it reaches a critical point, it engages and dislocates. Approximately 10% of patients following shoulder dislocation will have at least some element of neuropraxia, usually involving the axillary nerve, but can involve any element of the brachial plexus. In patients over the age of 40, particularly, we need to think about involvement of the rotator cuff, as tears are more common in this age group. This man dislocates his shoulder after a heavy fall and is noted to have very poor active range of motion and poor, particularly external rotation, indicating a major tear of the posterior superior rotator cuff. This is a similar patient who at exploration for an irreducible rotator cuff or irreducible shoulder dislocation has effectively a bald head with a complete rupture of all elements of the rotator cuff. Vascular injuries are uncommon, and one needs to have a higher level of suspicion in the older patient with atherosclerosis, particularly in those that have a fracture dislocation where the head is shorn off and in the axilla. And in patients who have this with an associated neurological injuries, you need to be aware that they may have either lacerated a vein or an artery which has been tamponaded, and when you reduce the head, you may face torrential bleeding. So indications for urgent surgical intervention include when there's a vascular or neurological deficit, where there's been an attempted reduction by an experienced practitioner which has failed, when there's associated fracture which needs to be fixed, or if there's a fracture secondary to attempted reduction. Then other indications for surgical intervention, perhaps not on an urgent basis, are if there's persistent instability, so if the reduction is performed and the patient remains unstable following the reduction. It can be considered in athletes, depending on the disease and other factors which we can discuss. If they've other patients who've had recurrent instability, and then if they have associated rotator cuff tears or fractures that need to be dealt with. And it's useful in the history to look at the number of dislocations, nature of the first dislocation, The age of the patient is very important in terms of predicting recurrent instability. The position of the arm at the time of the dislocation and whether it was hard or difficult to reduce, which may indicate the presence of perhaps a large Hill-Sachs lesion. Also, if the patient has had required surgery in the opposite shoulder, one generally has a lower threshold for operating on the second shoulder. In athletes, there are other factors such as return to play, and depending on the time of season, if the patient has a dislocation or subluxation and makes a speedy recovery, it may be possible to get them to play out the season and then to think about surgery at the end of the season. And one might be guided in this on the findings of an MRI or an MRA if they have a significant, for example, bony lesion. And other factors may influence decisions such as their sport and position, the level they're playing, where they are in their season and career, and there may also be contractual issues in terms of who wants them to play and who wants them to have their surgical intervention. These are the common interventions, either a arthroscopic labral repair with or without remplissage. In younger patients, we may combine this in an open fashion with a capsular plication. With increasing bone damage, we think about perhaps a lattice shape procedure, and in some patients, iliac crest graft. And arthroscopic labral repair is generally easy for both the patient and surgeon, with a quick rehabilitation, good range of motion, and patients tend to get a more natural range of motion than, for example, a coracoid transfer. I generally tend to perform this perhaps if the patients have had contact players have had singular instability episode and there's no significant bone damage, or if they predominantly have a posterior labral tear. Generally tend not to perform it in the revision setting. The key elements of the arthroscopic stabilization is, after careful diagnostic arthroscopy, to carefully prepare the glenoid neck and then liberate the soft tissue Bankart lesion to allow anatomical apposition of the prepared labrum to the glenoid neck. The labrum is then secured using various suture anchor devices. However, the issue with collision athletes is that we're dealing with high energy impact forces, which generally generate bipolar bone lesions, which are often not suitable for arthroscopic stabilization. Particularly in contact players, is that arthroscopic techniques have a high failure rate. It fails to address the bone loss and capsular laxity, and there's also a late failure, which is not seen in other types of stabilization. Effectively, a normal shoulder is not good enough for these type of sports. And the risk factors are young age, both glenoid and humeral, bone loss, hyperlaxity, the number of dislocations, biological failure, and to a lesser extent, the number of anchors that are used. The instability severity score is used to predict failure of arthroscopic stabilization. And if you look at the prognostic factors in terms of age, type of sport, degree of sport, hyperlaxity, and bone loss on X-ray, most of the patients that we see who play contact sports already have a score above 6, which predicts a failure rate of 70%. The ideal collision shoulder stabilization would in fact lead to a stronger construct than the normal shoulder, with allowing an early rehabilitation and predictable time for return to play. The latch-J procedure is ideal for particularly glenoid bone loss. It is a low recurrence rate and the equipment is readily available, and it's technically quite a straightforward procedure. It's becoming more popular particularly in collision players, but also in those with poor tissue or having failed arthroscopic technique.
The latch-J is performed through a deltopectoral approach. The coracoid is harvested using an angled oscillating saw. Then the coracoid graft is prepared and pre-drilled. Next, a split is made in the middle of the subscapularis and the capsule is exposed. The labrum is excised and the glenoid neck is prepared using a burr to present a bleeding surface for maximum graft incorporation. The graft is then secured using 2 screws. Care must be taken to avoid overhang or conflict between the screws and the humeral head. Solid compression is achieved by directing the 2 screws in a parallel fashion. The capsule is subsequently repaired we have performed a network meta-analysis of operative treatment of anterior shoulder instability, and the results showed reduction in recurrent instability or frank dislocation in the latch-J group versus either open or arthroscopic Bankart. There was an earlier return to play and lower row score indicating greater stability. However, there was a increased complication rate with latch-J procedure.
Other procedures that may be performed are a iliac crest graft, humeral osteotomy, the use of an allograft, or other complex type reconstructions. The iliac crest graft has been described particularly in a younger age group where it's often combined with a labral repair and in fact has been shown to have a high incorporation rate. It has been pioneered by Herbert Resch in Austria and reported on by Ralph Hertel, with a very nice incorporation of the bone graft in the long term. The Eaton-Hibney procedure uses a tricortical iliac crest graft in the case of significant bone deficiency on the glenoid side, and I tend to use it in failed latch-J, or if there's a contraindication to latch-J, and I've mainly used it in patients with epilepsy. We use quite a large graft measuring 4 centimeters long, and this naturally can lead to some graft harvesting morbidity. Another option is the distal tibial allograft, which is used by some US surgeons who ready access to tissue banks. And the distal tibia has this almost identical curvature as the anterior glenoid, so it's useful. So in summary, we need to think about the patient factors, their age, their sports, their position, their aspirations, assess both radiologically and clinically the glenoid bone stock, humeral bone stock, and soft tissue condition, and then look at our what is most appropriate in our surgical menu to best treat our patient. It's worth noting that as the operations confer greater stability, the downside is increasing complications. Well, thank you very much for your attention. I hope you enjoyed that, and I hope you enjoy the rest of the session for the rest of today. Thanks again.